Now, if somebody, you know what, I just realized I gave my partner this Zoom. So she's going to try to connect to this, but she shouldn't, right?
Oh, no, she shouldn't. She should.
I'll tell her not to.
Yes, you should just go on our Facebook page.
Okay, just a minute.
I think we are live. Okay. Yes, we are live on our page.
Wonderful.
Hello, everyone. Thank you for joining us. We're going to get started in 2 minutes with Dr. Michael Narvi. Thank you, everyone who is joining us here today. We'll start our chat with Dr. Michael Narvi, neonatologist from Winnipeg, in just 1 minute. You're welcome to say hello and ask your questions on the comment in the box below your screen. You can say hello and tell us where you are logging in from. Hello, thank you all for joining us here today. My name is Fabiana Bacchini. I'm the Executive Director of the Canadian Premature Babies Foundation. We are committed to continue to educate and support NICU families every step of the way, and especially at this time of uncertainty and when things are changing so rapidly. Every Monday and Friday, we are hosting Facebook Live with experts in different areas, and you can send us your concerns and questions so we can ask them. And every Wednesday, Kate Robson, who's a psychotherapist and also a mom of 2 premature babies, is hosting a real-time peer support groups online. You can join the groups by joining our Canadian Preemie Parents Network on Facebook, and is a link and is a group just for parents. The links will be posted there every Wednesday morning. And this group has over 2,400 parents from all over Canada sharing experiences and resources, so you know that you are not alone. So today is joining me Dr. Michael Narvi. He's the section head of neonatology in Winnipeg, a medical director of the Child Health Transport Team. He's also the chair of the Fetus and Newborn Committee at the Canadian Pediatric Society. He's very active on social media, and you might follow his wonderful blog, All Things Neonatal. He starts sharing information with healthcare professionals, and in January, he launched the Parents Corner, where he translates the medical terms to terms that we parents facing the NICU and prematurity can understand. Dr. Michael Narvi, welcome, and thank you for joining us here today. I know this is Thank you. This is a very busy time for you, for sure. Not only the hospital, but also keeping our blog update with the latest information on COVID-19. And we so much appreciate that. And this morning, just a couple of hours ago, the Canadian Pediatric Society from the Fetus and Newborn Committee just released the new guidelines to address the risk of vertical transmission as well as delivery room care of a newborn whose mom is suspected or confirmed to have COVID-19. And you are the principal author of that guideline, as well as the other guidelines we're going to be talking about here today. So what can you tell us about it?
Well, I can tell you that this is a very quickly changing field when we talk about COVID-19. And I'm really proud of the work that we did. And although I was the principal author for these 3 practice points, I truly couldn't have done the work without the board of the Canadian Pediatric Society and the edits they gave me, as well as my own committee members and external organizations or external committees such as the SOGC, and within the Canadian Pediatric Society, the Infectious Diseases Committee as well. I think we should all be happy to have these practice points present now in the Canadian landscape, because there are so many questions. I hear them here in Winnipeg and certainly from across the country. I've received many emails. And I just wanted to point out that I think one of the great ideas that the CPS had was originally this was all one large document. And in order to try to make it easier for people to find the information that they need, we decided to break them into three. And so I think you mentioned them, but just so people are aware, the first one addresses everything up to the birth, so that one's called Delivery Room Considerations for Infants Born to Mothers with Suspected or Proven COVID-19. The second one then addresses what happens when you get to the NICU. And that one is NICU care for infants born to mothers with suspected or proven COVID-19. And then the last one, which I think is probably of great interest to many of the listeners today, is breastfeeding when mothers have suspected or proven COVID-19 and considerations around that.
Thank you so much. So if we start talking about moms who are pregnant, and there's a lot of anxiety around the delivery itself, whether the mom knows they're going to deliver earlier or they are almost reaching term. There's a lot of anxiety around that. Are moms getting tested before for a safe delivery? What is the protocol at this moment?
Well, that's a wonderful question. And I'm probably going to sound like a broken record today when I say that it's subject to change and that intraprovincially there may be differences in approach. But in general, I think that what the last week or two has taught us is that using a screening approach that really focuses on travel no longer is that significant. I think many of the listeners or viewers would be aware that all of the snowbirds have come home pretty much now. And so the 2-week period where we were watching people under quarantine has really elapsed. And we're starting to now see evidence of community spread right across Canada. So certainly one thing that I think is important to mention is that we don't screen those people, excuse me, we don't screen those people who are asymptomatic. If we screen people who are asymptomatic, we know there's a high likelihood that those tests will be negative, and therefore we don't recommend doing that. But if you're symptomatic, and by symptomatic I mean if you have a cough, if you have signs of pneumonia, especially if it's confirmed on chest x-ray, if you've got a sore throat, high fever, in this era, that's someone who would likely be swabbed regardless of where you are. However, much like it exists in Manitoba, people are advised to call information lines and find out if they need to be swabbed or not.
Okay, so how about, there's also a lot of people asking us, are fathers or partners being allowed in the delivery room?
So that is a really, really good question. And, it's funny, I was just asked that question through the CPS this morning as well. And, I think one has to take a practical approach to this. Given that many hospitals now have moved towards universal precautions. Now, that doesn't mean, I don't want to alarm people, that doesn't mean that everyone needs to don an N95 respirator. But what it does mean is most hospitals, or at least many hospitals now, have implemented presumption that all people coming in could have COVID-19, and therefore gowns and masks and gloves need to be used. The situation with partners is an interesting one because I think it really pivots around whether the mother is likely to need a general anesthetic or not. If the mother is not likely to need a general anesthetic, so that would mean she's either having no analgesia from whether it be a spinal or a epidural, more commonly epidural with vaginal deliveries. If there's a very low likelihood or no likelihood that there's going to be a conversion to a general anesthetic, the partners could be in the room. The issue becomes if mom is likely to need a general anesthetic, because once we intubate and put a breathing tube into a mother, there's lots of particulate matter that can enter into the room in terms of the air. And that's where you need to have the N95 respirator. Mm-hmm. Now you might say, well, then why not just get the partners to all don an N95 respirator for a cesarean section? But for anyone who has already worn one, you would know that you have to be fit tested. And that takes time with some sophisticated testing. So unless somebody happened to know what their N95 size was, the safest thing would be to keep the partner out of the room while mom is having a breathing tube put in. And once she has the breathing tube taken out and is taken to recovery, we would bring the partner in.
Okay, that's great. So this brings us to two comments. One is like people in the community should not be wearing the N95 masks because people have been posting other people in the community using them. Just really leave those masks for healthcare professionals who actually need them in hospitals.
Correct.
And second, my question is C-section safer if a mom is positive as a delivery method, or a vaginal delivery is still an option if the mom is positive or suspected with the virus? Do we have that in the guideline?
Yeah, well, we don't have it specifically in the guideline whether cesarean section or vaginal delivery is preferable. And I would, draw the listeners or viewers to the Society of Obstetrics and Gynecology, the SOGC. They may have something on that. But your question, as with many of them today, is very timely because just a few days ago, there was a publication, the first of its kind, that came out that I think provides some answers or some evidence that would help guide local institutions. And what that study did was, it was the first of its kind to really look at testing of vaginal secretions for COVID-19. So there were 10 mothers who all delivered vaginally. They had their secretions tested. And the tests of the secretions found that on PCR, which is a form of DNA testing, the secretions were all negative for the virus that causes COVID-19. So previous research had demonstrated that out of China, that when they looked at cesarean sections, that the amniotic fluid was negative for the virus as well. But questions remained about could a baby be born and covered, in secretions which may be teeming with virus. But the good news is that does not appear to be the case. So from where I'm sitting, and remember, I'm a neonatologist, I don't deliver babies, but from where I'm sitting, I would suggest to you that there is no difference in terms of risk, in terms of delivering either vaginally or via cesarean section. And I would encourage people to have the mode of delivery determined based on the common indications for each.
Okay, so are the babies being tested?
So this is a very hot topic, and again, will differ depending on where you are in the country. What we have recommended in one of the practice points that has been put forward is considering testing in a couple of situations. So one is, we have currently less than 100 babies in the literature that have been delivered and have been tested at birth for COVID-19. The good news is all the testing that's been done so far around the time of birth, and when I say around the time of birth, I mean within the first few hours of birth, there have been no babies that have tested positive for the virus. So if we wanted to add to the literature, so almost from a research standpoint, but also if you as a hospital wanted to know what your own information was, what your risks were, the practitioners may want to know whether or not this vertical transmission, which is from mother to baby inside the womb, is possible. Then you would do this early testing. The other thing, though, that we can rely on is if mothers have been tested, I see no reason if the mother comes back negative to then test the baby, provided the mother was symptomatic. Again, if she was asymptomatic, testing her might be falsely negative. But if they're symptomatic and mom comes back negative, I don't think you need to test the baby. The big question, though, is what do you do if you have a newborn who, after 24 hours or 48 hours, begins to develop symptoms, coughing, sneezing, increased work of breathing, a need for oxygen perhaps, or fever. Those infants in this day and age, I think, will likely get tested. And what we do know is, because I did sort of tease you that, no one around the time of birth has tested positive. There's been, the media sort of, I would say loves a good sensational story. And there was a story out of London, England, that there was a baby that tested positive within minutes of birth. That media story, which I believe may have been in The Guardian, has never been published in terms of a scientific paper. So I can't say for sure that that patient was correctly identified. We do know that the earliest documented case of COVID-19 in an infant was at 36 hours of age, and that was out of Wuhan, China. Recently, there's been 3 additional patients who tested positive at 48 hours of age out of a cohort of 33 infants in total that were tested. So which does, I think, raise the point, which I wanted everyone to hear, is that we don't just need to be careful at the time of delivery. We need to continue to be careful after the birth and try and prevent infection after birth. And we call that horizontal transmission, because you would have heard a lot in the news about vertical transmission. Well, horizontal is transfer from either mom or a healthcare provider or partner or someone else to the infant after delivery.
Thank you so much. So now I think I want to move a little bit to the NICU. How are those babies getting transport from the delivery room to the NICU? And what are the guidelines when the mom is positive or suspected and babies transfer into the NICU?
Well, this comes down in my mind to whether the baby has symptoms or not. And we have to bear in mind that many infants who go to NICU are in there because they're born prematurely. And premature infants are far, far more likely to have a cause of breathing difficulty that is related to something like respiratory distress syndrome from lack of surfactant, transient tachypnea of the newborn after a precipitous or quick labor, or a pneumothorax, air outside the lung. There are many causes that lead babies to go to the NICU. If we take the evidence presented thus far in the literature, it's unlikely that any of those babies have COVID-19. So a practical approach to this would involve looking for symptoms first. If you have a baby with no symptoms, no coughing, no sneezing, no excessive secretions, there's no reason to think that a baby such as that could not be transferred, if they're asymptomatic, to the postpartum ward in an open crib or isolette, a bassinet, sorry. If the baby, though, is going to the NICU, you would certainly have the option of using an open bassinet if they are asymptomatic, or the unit might decide just to move all babies in a closed isolette or incubator, as some people would call it. The advantage of being in the closed isolette comes into play if there's symptoms. So if a baby has problems with their breathing and they need to go on CPAP, which is continuous positive airway pressure. So some of the adults listening would be familiar with that. If you have a loved one who wears a mask at night to prevent them from snoring and having sleep apnea, we use the same thing, of course, in newborns, or if they're intubated. The air that's exhaled from the baby could have airborne virus particles present. And therefore, if you put them into an isolette and close it so that everything's contained within the isolette, that would be the safest way to transport them to the NICU, again, if they're on respiratory support.
Thank you for that. So my question now is, because we know the guidelines from the World Health Organization, as well as the CPS today, not to separate moms who are positive from their babies. They can still breastfeed, share the same room, and do skin to skin. So I guess this applies for moms who are taking the babies home with certain precautions in the hospital where they deliver. But how about the moms whose baby going to the NICU? Are they still able to pump, to provide breast milk, if it's a late preterm, to breastfeed or do skin to skin? What are the recommendations today? I'm going to ask it today because it all can change tomorrow.
Yeah, had you asked me a week ago, they would have been probably different. But when we're talking about the neonatal intensive care unit, there's a couple of things that we need to consider. Number one, although the evidence that we have thus far is that the infection is not likely to cause significant illness in children, that we do have a need to protect the healthcare workers, but we also don't quite know what COVID-19 would do to somebody, let's say, who is born very premature at 24 weeks or 25 weeks. We just don't have that information yet. Because we don't have that information, an abundance of caution needs to be practiced. And what I mean by that is, and this is going to be difficult for viewers to hear, but as we are doing in Winnipeg, if a mother is COVID positive, or if for that matter, if she's even COVID suspect, until we know she's negative, we are having mothers and partners not visit, which I have, no doubt puts a lot of strain on a new mother, a new father, or a new partner. But we have to care for the babies. We have to care for the workforce. And you mentioned pumping, and that's what we need to do. We need to advise mothers to clean their chests with soap and water prior to pumping, make sure they use proper cleaning for their equipment, and store the milk. And don't think it's all for naught. We need you pumping, because when your baby does come home, or when you're able to come back to the hospital, we need you to have good supply, because that's what's best for the baby. So even though in the early stages, there will be that separation, it is the best thing for all concerned. And I would mention, because I think this was a great comment that somebody made to me the other day, and I've shared this with you before. There's been so much focus in the news about ventilators, that we need to get more ventilators. But the issue will become, if our healthcare workforce becomes severely diminished because of horizontal transmission, community spread through the hospital, who will run those ventilators? So that's one of the reasons why we are taking this extra precaution. So I would ask for families, especially if there's people listening right now that are expecting a preterm delivery or expecting a baby that will need an NICU admission, please have patience and please have understanding that this will also pass at some point.
Thank you for that, because for sure there's a lot of anxiety. And I'm going to ask one more question before we go to the comments and the questions that are coming on our feed. Obviously, parents' presence in the unit has always been something that we advocate for, that we have been working with healthcare professionals across Canada and many organizations around the world. And with this pandemic, the presence of parents have been limited in most of the hospitals in Canada, and some countries are completely closed for parents to come in altogether. It caused a lot of anxiety for families. Most of hospitals in Canada, as far as I know, is one parent on a 24-hour period. Is there a way that we can still support families during this time when one parent can come, the partner or the dad cannot come because it's not the person who is breastfeeding the baby? How can we better support families at this moment in time?
Well, one of the things is something we're doing right now. That's the first thing that comes to mind is, I think we are forever going to be changed in terms of the way we provide healthcare by using technology such as video conferencing, telehealth, in order to connect families and their babies. There are many units already. I certainly don't want to give out brand names, but there are certainly units already that have employed such technology to allow portals through which the families can access their infants. And I would encourage units across Canada to look and explore, especially given the situation we're in, how best to do that and facilitate. It's not the same as touching, I know that, but at least facilitate televisitation with their infants. And the other thing that I would mention is check when your babies are admitted to the NICU. It's okay to ask and advocate and check with the NICU as to what are their requirements for lifting of isolation. That's another thing that will differ depending on the area of the country. Is it one negative test for COVID-19? Is it two negative tests for COVID-19? Is it lack of symptoms for a period of 24 hours? All of these things will determine how long you are separated for. And I would advise you be an advocate for your child and speak to the managers or speak to the neonatologists to seek clarity. Because I would imagine, as a fellow parent, having this uncertainty of when will I get to see my child causes a lot of anguish, and a little bit of information could help.
Thank you, Dr. Narvi. Now I'm going to go to some of the questions and comments that are coming on our feed. So this person asked, I go into the hospital every day to deliver milk, pump, and to provide kangaroo care. I feel most comfortable wearing a mask during kangaroo care, given that I've picked up essentials the last 2 weeks and I've been at the hospital every day. In recent days, this has been a contentious issue, and I've received pushback from some nurses for using a mask. Should parents be allowed to use a mask for extra precaution to protect their babies?
Well, certainly here in Winnipeg, we're not insisting that mothers or fathers, for that matter, wear masks if they're asymptomatic. But I think where this is coming from is that there's concerns right across Canada, not just Canada, the globe, that we're running out of such supplies. What I would advise people to do, because the easy thing to do, I would love just to say, sure, wear a mask, and then have everybody wear a mask. But we are faced with limited resources. But if you have your own mask and you choose to wear your own mask, personally, I don't see why that would be a major issue. But if we're using consumables, every time we use a consumable, that's one less mask out there for someone who actually might truly need it because of risk. So far, my advice would be, if you have symptoms of a cold, if you have pneumonia, by all means, you should be tested, and you should also be using a mask if you are allowed into the hospital. But if you're feeling perfectly well and the hospital doesn't advise it, I don't know that that's really required.
Okay, thank you. If a father of a premature baby in Winnipeg is unable to visit their child, what are they doing to ensure parental access to the child if they determine the child will not survive before the parents are cleared?
So there we're talking about special situations. There needs to be consideration of these situations, and that's not just in Winnipeg, but across Canada. In the situation where there was palliative care being considered, or there may not have been palliative care considered, but the baby has taken a significant turn for the worse, and it is expected the baby will not survive. I believe that every institution needs to make considerations for these, thankfully, rare events, and do what they can to allow the family to be there to support their infant. It's important to remember all of this is done due to caution around trying to limit spread of infection, but at the same time, we can't lose our compassion in special situations such as that.
Thank you. We have a lot of comments and questions coming. I'm not sure we're going to have time to answer them all. But one question that a lot of parents have been asking us, if the child was born prematurely, and we know we are at a higher risk of contracting respiratory illnesses and viruses, are premature babies at a higher risk of contracting COVID-19?
The short answer is we don't know. What we do, I'll tell you what we do know. One thing that I didn't mention, but I think is very useful information for people out there is, as awful as COVID-19 has been, there's one thing about COVID-19 which I am grateful for, And you might find it shocking to say anybody's grateful for anything about COVID-19. But COVID-19, for those of you who remember, we went through SARS back in 2003, 2004. We then went through MERS, the Middle Eastern Respiratory Syndrome virus, I think around 2012. And both of those viruses are actually also coronaviruses. They're just different coronaviruses. But the problem with those two viruses was that they caused a lot of preterm deliveries. COVID-19, for whatever reason, does not. We don't seem to see, we're not seeing more preterm deliveries related to COVID-19, which is one thing that I wanted to sneak in because I thought people also might be wondering, am I at risk if I get COVID-19? It doesn't seem to cause preterm labor, which is good. We do know that immunocompromised people or people with chronic medical conditions are at increased risk of developing severe symptoms of COVID-19. The only real data that we have on children is in a study from China that looked at babies from about a day or 2 days of age all the way up to 17 years of age. And there were over 2,000 pediatric patients. And what we know is 94.6% of those patients in that study had either mild or moderate illness. What we don't know, because there wasn't enough granular detail in the studies presented, is whether any of these were preterm infants. And of the preterm infants, what happened. But given that we haven't seen yet an outpouring of case reports of preterm infants who suffered severe COVID disease, at the moment, there doesn't appear to be any evidence that COVID causes severe disease in the preterm infant. But again, we are at the very, I hate to say it, we're at the early stages here. We just don't have a lot reported in the literature, but common sense would suggest that these fragile infants, we should be protecting from getting COVID, because truthfully, I don't want to see what a 24-week infant on a high-frequency ventilator will do if exposed to COVID-19. So please wash your hands, wear your masks, and stay at home if you can.
I think that is the key message that we can hear coming from every part of the world, just to stay home and wash your hands. I'm gonna, there's one more question here that is something that families will be seeing in the news. What is the protocol if you have positive team members in the NICU? Closing immediately or screening staff day to day? And we just heard today there was an outbreak in a special nursery here in Ontario, and the hospital taking all the measurements possible. Apparently, the 2 nurses were tested positive, but only one had contact with families, and she was wearing protective equipment. Is this the approach that hospitals will be taking, or in any other parts of the hospital if staff is tested positive? What's happening now?
Well, this is an extremely hot topic.
Sorry to put on the spotlight, but questions are coming on our feed.
No. I think it needs to be. It's actually a point that really needs to be addressed, because certainly I'll put a disclaimer on this and say that I am one physician. I am not making decisions for government, so I'm not speaking for the government here or Shared Health in Manitoba. But one of the factors that we need to think is what is ideal versus what is practical. So if we were to say that any close contact of these workers need to be removed for a period of 14 days of isolation, when you think about all the contacts that one has over the course of the day, as you're walking through the unit, you're going from one module to another, you're checking into the locker room perhaps, lots and lots of contacts. And the healthcare workers, as I mentioned earlier, are such a precious resource. So as community spread occurs, and as we see COVID-19 in the hospitals, if we were to enact a policy that all healthcare workers, doctors, nurses, respiratory therapists, dietitians, everybody that comes in contact with these individuals have to go home, I fear that we won't have a workforce. So perhaps, and this is a question, now that we are in an era where most places now are using universal precautions, is it possible to is it possible, to self-monitor and return to the workforce if you are needed? And that's where I think the big question comes. Ideally, if somebody can be at home and self-isolate and self-monitor for symptoms, that would be great. But if we are unable to provide a workforce to care for ventilated patients, patients on CPAP, patients who need us in the hospital, one has to then weigh which is worse, to leave the hospitalized children and newborns or adults unstaffed and have nurses stretched beyond their means. I think you're going to see a lot of errors. So I think that hospitals across Canada are now having to look at their policies around return to work and trust that because we all want to help, that if we do have a fever or develop a sore throat or a cough, not only will we self-isolate, but we will have used personal protective equipment to prevent the spread, even if we were infected, to anyone. And so I think that's probably the practical approach that people are going to move to.
Okay, so Dr. Narvi, thank you so much for joining us here today. There was a lot of more questions on our feed that we were unable to answer them all because of the time. I really want to thank you on behalf of all the members of our organization for all the work that you do. And we are so grateful to all the frontline workers really working hard on this pandemic and supporting the families the best that we can with the resources that we have available at this time. So thank you so much. And I hope I see you again in the next few weeks as things change. And I'm hoping we see an end of this very soon.
I agree.
That's the hope that we can all have, because it's already hard enough to live in fear and isolate in our homes. So let's all stay home for the time being, so then we can get out of our homes before summer starts, hopefully. So join us here again on today's Monday, on Wednesday, when Kate Robson will be hosting a real-time peer support group for families. And also Friday, I'll be interviewing Jack Horrigan. She's an amazing mom of a preemie girl who is gonna give us amazing tips on how can we support our children at home and activities we can do at home with our babies. So please stay tuned and follow our social media channels to all the experts we're gonna be interviewing in the coming weeks and the new developments of the pandemic in Canada. Thank you so much. And just remember, we are all in this together. This might end soon, hopefully. Right, Dr. Narvi?
Absolutely.
Thank you.
This will pass.
Thank you.
Okay.
Bye for now.